So as I mentioned, my name's Kathleen. Everyone calls me Kitty. I work in the Department of Senior Services, handling the University Express project with my co-workers, Katie and Elisa. And it's been a lot of fun, and we're already looking forward to the spring schedule. We're starting to work on that now, even though there's 7 feet of snow where I am. Well, there was, but melting quickly. So on behalf of our commissioner, Angela Marinucci, I want to welcome you to University Express. It's our lifelong learning program for adults 55 and older. Combating social isolation and loneliness among older adults is one of Angela's main goals for our department. A great way to do this and also learn some new information is through University Express. So thank you for being here today. I also want to take a moment to thank our hosts, or our special speaker today, Sue Stoklosa, and I'll talk a little bit more about her as we move on. We want to recognize our sponsors, Highmark Blue Cross Blue Shield of Western New York, Excelsior Orthopedics, Wegmans, and of course, the Department of Senior Services at Erie County. And don't forget all the services we offer. If you or anyone is in need, please give us a call at the department, 858-8526, or go to our website, erie.gov/senior services. We have a Stay Fit Dining program. We have Choose Healthy Western New York workshops. We have a benefits enrollment center. And we also have a way to connect our seniors with a volunteer project. So keep that in mind. At the end of this WebEx, you'll see a survey. It's a quick survey. If you want to just fill that out, we would appreciate it. It helps us to determine what kind of classes our attendees are looking for, and also to let us know what we could do better. So take a minute to do that. That's always important feedback. So now we'll talk about Sue. Sue has been with the University Express program for a number of years. She is a nurse practitioner with 13 years of experience in pulmonary and critical care. In this practice, she managed and educated obstructive sleep apnea patients. Otherwise known as OSA. I remember we did a class on that last year. Sue recently lectured on OSA at the New York State Nurse Practitioner Conference. She currently teaches the next generation of nurse practitioners at Damon College. And Sue is also a certified basic life support and advanced life support instructor. So welcome, Sue, and you can take it away from here.
Thank you. Great to be here. As the snow is finally melting. So, thank you for all joining us. I'm going to be talking about heart failure, and many times it's referred to as congestive heart failure, chronic heart failure, or you'll see the initial CHF. It is one of the most common diagnoses in us older people, and also it is usually number 1 or number 2 of admitting diagnoses to the hospital. So it's a large segment of the population that has heart failure, and it doesn't mean your heart has failed. It's just that it's having trouble working. And we'll talk about that, give you a little bit of anatomy, just so we know what we're talking about. Little bit of some of the causes, how they diagnose it, and most importantly, since it is a chronic problem, what we all can do to manage it, because you have to manage it on a daily basis. Okay, let's see if we can change the slide here. Come on. Uh-oh. There we go. So first, a picture of the heart. So the heart sits a little bit to the left in our chest. there's basically two sides to the heart that we refer to. The right side and the upper there's 4 chambers. There's the right atrium, right ventricle, left atrium, left ventricle. So the blue, so we have the inferior vena cava, superior vena cava. That brings all the venous blood, or the blood our body has already used, gotten their oxygen needs out of, taking the carbon dioxide back, comes into the right atrium. There's a valve here, and the valves help it so, like plumbing, you don't want it to back up, you want it to go forward. And it goes into the right ventricle. And from the right ventricle, it is pumped out to the lungs. And in the lungs, the blood gets oxygen. We blow out the carbon dioxide, comes back from the lungs to the left atrium, through the valve again, into the big pumping part of the heart, the left ventricle. And then that's pumped out through the aorta all over the body. These are the carotids that goes up to the head, and then the aorta comes back down almost to the whole length of around the kidneys, the abdomen, and then it forks off into another vessel. So here's another picture of just how the circulation looks. So the blue is the venous blood, or the blood that's already had the oxygen taken out, the carbon dioxide they're taking from the cells, bringing it back to the heart. Then it goes into the right side of the heart. It's pumped into the lungs. And you see here, the lungs fill that blood up with oxygen again, gets rid of the carbon dioxide. That's what we blow out. And the fresh oxygenated blood comes back into the left side of the heart, and again, pumped out to the rest of the body to give every part of our body needs oxygen, including the heart. And around the heart is the coronary arteries. And those are the vessels, the arteries that provide blood and the oxygen to the heart muscle. Just like every other part of the body, our heart needs the oxygen to stay alive. So these vessels here are on the outside of the heart, but go into the muscle itself. So here's a big coronary. Here's what we call the right coronary artery. Here's the left coronary artery. And then there's veins that take it back. So the heart itself has its own blood supply. This is where we get the blockages, or the people, doctors will tell you that you have coronary artery disease or heart disease. So we get plaque and fat globs. There's a medical term, globies, in the vessels inside these coronaries. And then it slows the flow. So it could decrease the flow. So say you have 60-70% blockage in that coronary. So that means that, if you have this round thing, 70% of it is blocked with this plaque and fat. And you may be doing fine with that when you're sitting or not doing too much strenuous, but when you go to be active and the heart muscle needs, more blood because it has to work harder, that may be the times where you get fatigued or chest pain and things like that. A complete occlusion, that means that whole artery is just blocked. And generally what happens is you have like a 70% occlusion. I'm just using that and then for some reason you get a blood clot. The blood can't move through there, and it clots in there. And you have a complete stoppage of blood flow, like say here, to the muscle that it's supplying. And that's what we call a heart attack, or in the fancy, medical terms, myocardial infarction. And part of the heart muscle dies because it didn't get any oxygen or blood, just like any other part of our body. If you don't have oxygen for a certain length of time and the blood flow, an area will die. And that's a heart attack or a myocardial infarction. And then part of that muscle that's dead doesn't work anymore. This isn't a great slide, but just to show you, so we have the buildup here that occurs over a long period of time um, um, with the plaque and the fat cells. And then we get a complete occlusion when the blood maybe it doesn't flow well, or there's some clotting. Your body wants to clot more, and there's a blood clot. So you say you have it here. This purple part is part of the heart muscle that's going to be damaged or dead, not pump the way it should. And that's where that leads to the congestive heart failure, because that's all about pumping and moving the blood, how the heart can do those things. So how do they diagnose congestive heart failure? Well, they can do x-rays, and x-rays can show that there's maybe fluid in the lungs or the heart is really large. Usually the first thing they'll do is something called an echocardiogram, which is an ultrasound of the heart, and it can show us how the heart is functioning, how it's pumping, how the valves are working, and I have a picture of that coming up. So it'll show how efficient the heart is. One of the things we look at and throw around is a number called ejection fraction. And what that has to do with is how much blood the left ventricle, that's the big pumping part of the heart that pumps out to the rest of the body, how much blood it pumps out with each contraction. We don't pump 100% of our blood out of the ventricle every time our heart beats. We pump out, a normal one is 55 to 65% of our blood in that ventricle will be pumped out with each contraction. And that shows us that the heart muscle in the left ventricle is doing the job and pumping the blood at a sufficient amount to get blood everywhere to the body. When we start going down, even when we get down to 45 or 40, we start, the heart muscle is not doing exactly what, as much as it should. Below 35%, generally, you're going to have symptoms of heart failure. They may do a stress test because, as I'll show you, there's many reasons to have congestive heart failure. The most common is what I showed you with a heart attack and coronary disease, because that's the most common problem us Americans have with our hearts. So they may do a stress test. There's several different types of stress tests. We always think of where you're on the treadmill and your heart rate's going up. And well, for many of us, we can't do that. We can't exercise to that level to get your heart rate up that high. So they'll do what's called a chemical stress test, where they'll inject some medicine that will get your heart rate up from the medicine, and then see if you have any problems with the blood flow to the heart. They may do something called a cardiac catheterization if they want to see, because an echo will show the functioning of the heart, the outside of the heart, but it doesn't show the blood flow through those coronary arteries. So if you let's say go to the hospital for the first time in congestive heart failure, they may have to do something like a cardiac catheterization to see what is going on with the coronaries. So this is a picture, actually. What they do is they go into an artery, most of the time now in the wrist, put a long catheter in, and under this big fluoro, and they have big screens in the room, they will inject dye, and the dye will go through the coronary arteries on the outside of the heart and see if there's any blockages. They also will they can look at the pumping part of the heart, the ejection fraction, just like in an echocardiogram. So this is a picture where the dye is injected. This is a coronary artery. And you see here where the big arrow is. See how narrow it is through there. So that's a blockage. That's a coronary blockage. You are still getting blood flow, and you're getting, obviously downstream we have blood flow, but that's what the cardiologist would say, pretty tight. So this would be something they could open up with a stent. And probably a lot of you have heard about that. They go in, say, the same way with a catheter, and there's a metal tube that and with a balloon, they place it in through there. They inflate the balloon, and that metal stent adheres to the artery and opens up that artery. They'll do some blood work, to see, again, looking for sources of the heart failure or how well the heart failure is controlled. They'll look at blood counts, particularly hemoglobins, to make sure you're not anemic. Thyroid levels, the thyroid, if it's off, can contribute to heart problems. What your kidney function looks like. Your kidneys and your heart are very closely, they're real buddies. So if the kidneys are having problems, that may backflow to the heart. If the heart's having problems, that may injure the kidneys. The kidneys are very, very, very sensitive to blood flow. So if the heart can't pump as strong as it should, and it can't get the blood flow out to the body and the kidneys in the level that it should, you can have kidney problems also. A BNP, this is an enzyme that when your heart muscle is stretched, it will be released, and you'll have a higher level of this peptide in your blood. So it's a marker for heart failure, and it's also can be used if we know you have heart failure, and we're monitoring how well it's being managed. If it's managed well, that number should be lower. And lipid profiles. We need to look at, keep your cholesterols controlled. Most of these blockages start off as a soft, fatty cholesterol, loopy stuff adhered to the arteries, and with what they call a cap on the top. Over the years, that becomes a hard plaque, but it starts off as this cholesterol plaque. So keeping the cholesterols within the right limits is a good idea. We moved. Okay. They'll do an EKG to see if there's any prior damage or anything with the heart. Oxygen studies, very important. We'll talk about some reasons, probably, I don't know, second, third reason for heart failure is oxygen issues. And many of those are nighttime oxygen issues. And that's why I have a sleep study down there. They may want to do a sleep study. When your oxygen levels are low, one of the things that happens is your blood vessels, particularly in the lungs, tighten up, or what we call vasoconstrict. When your blood vessels are tight, the pressure goes up. So your blood pressure will go up. The pressure that the heart has to pump against will go up and cause damage to the muscle because it has to pump against this high pressure. Also, if your oxygen is low, your heart's going to not get enough oxygen too. So heart failure can be very much associated with sleep apnea or oxygen, even oxygen problems during the day. And generally the number is you want to be above 90% on your oxygen levels. All right, so a couple chest x-rays. So so this is a normal chest x-ray. Just to give you some bearings, here's the collarbone, okay? This, where you see dark on an x-ray, dark is air. White is either an organ or tissue, okay? So down here, here's the trachea, where you're breathing in air, and it's the opposite, right lung, left lung. Here's the diaphragms. Right here, this little, that's the gastric bubble because you have air in your butt, in your stomach. And here's the heart. And this is what the heart should look like. This is about how big it should be. You see area of lung between the edge of the heart and the lung. This, you have a little bit of white stuff because these are the blood vessels coming off into the lungs and back to the heart. So this is a normal chest x-ray. Now, if you look over here, the first thing you notice, look how big this heart is. And this is over time, because this heart had to pump against probably a lot of pressure, like say high blood pressure, this has gotten, the muscle has stretched out and out and out. And you know, it gets to a point, like our stretched out sweatpants, where it's so stretched out that it doesn't come back. So you don't have that good contraction. You have kind of boggy heart. That isn't, it isn't pumping very effectively. And you see more white in here than dark, like this one. And that's mostly fluid that's backing up into the lungs. Just again, like plumbing, if you have something that isn't pumping right, and then you get backflow. You get backflow to the lungs, you get backflow to your legs. That's where you get the swelling and the fluid in the legs, because it's backflowing because your heart can't pump the blood efficiently. This is an echo, just an echocardiogram, just to show you what it looks like. You're really getting the function of the heart, not like how the internal stuff looks. And the odd thing, go back there. The odd thing about an echo is it's upside down. So here's the atrium. Here's the atrium, which is really on the top of the heart. And here's the ventricles. And the big part of the big one here is the left ventricle. This is the right ventricle. And look at the valves opening and closing. So they do all kinds of measurements. They measure the thickness of the muscle. They measure how big the chambers are. They have like ultrasound that measures the blood flow through the valves. So they get a lot of information from these echocardiograms. So types of heart failure, and basically it falls into two groups. So I'll go back to blood pressure. And we all know we have our blood pressure taken and we have two numbers. So let's use a nice number like 120/80. So what does that mean? 120 is what we call the systolic blood pressure. That is the amount of pressure in the peak amount of pressure in your blood vessels when the heart pumps. So when the heart pumps, there's pressure in the blood vessels, sometimes high, but say it has to pump against 120 millimeters of mercury. The diastolic, or the bottom number, the number 80, is the resting number. So that's when the heart isn't, in between heartbeats, what the vessels just resting pressure is. So you can see when we're talking about high blood pressure that the higher either one of those numbers are, the more strain it puts on the heart. So the heart failure can fall into these two big categories called diastolic or systolic heart failure. In diastolic failure, and that's the picture here, so then we're talking about the resting, the pressures before the heart beats. These areas, these right and left ventricles, the chambers, the muscle part of it becomes stiff and thick. And again, a lot of times from things like lung disease, because this chamber, it has to pump into the lungs, or high blood pressure. So the issue here is that the heart can't fill as much with blood because, and these are not relaxing the way they should between the heartbeats to be able to fill with enough blood. They're always a little bit tight, so it can't fill as much. Systolic heart failure is the heart can't pump. These, see how the picture is that we're starting to get the heart enlarged, the muscle mass itself, because this is the muscle. This is the muscle here. The muscle mass itself, even though the heart is bigger, it's not pumping. So these are thin, stretched chambers. So you can see again, if you have something that's overstretched, it just can't pump, and it doesn't have the muscle mass that a normal heart would have. Why does that matter? It matters sometimes, well, it matters because some of the diagnostic and the numbers the healthcare people look at are different, a little bit different in the medications and how we treat them too. So systolic heart failure, again, normally this is the blood flow. When we see that weakened muscle, it can't squeeze as well. So the blood flow is less. And sometimes too, as everything gets stretched out, these valves don't come together as well as they should. This is how it should look, right? We saw the echo, and you get stretched out, and maybe they don't come completely together. So now you have some blood flow that backs up too. So just again, so systolic heart failure is the pumping part. It's a pumping problem. The heart muscle is stretched. This is where we get into that number, that ejection fraction I was talking about, how much blood is pumped out of the heart with each heartbeat. And many times with systolic heart failure, you'll see that is reduced, less than 40%. It's usually the marker. With the diastolic heart failure, it's a filling problem. We don't get as much blood into the chambers. The heart muscle is thickened. The pump part of it itself, the ejection fraction, may be normal, but the amount of blood is different, is reduced. We also, and you may see this, if you have heart failure, your doctor may have talked about this. There's a New York Heart Association classification, and it's used all over the place, not just New York State. They just came up with it in New York State years ago. So there's 4 classes of heart failure. Number 1 is you don't have any symptoms, really, but you can do you can climb stairs, but you've had some changes on your echocardiogram, let's say. Class 2, you have some mild symptoms or slight limitations. So with your physical activity, you come up a flight of stairs, you're short of breath, or your stamina is reduced with your walking. Class 3, you really start to have symptoms. You have symptoms less than ordinary activity, like they say walking 150, 300 feet, but you're comfortable at rest. In class 4, you have symptoms even at rest. Some of the causes, and we'll talk about whether some of the symptoms, some of the causes, like I said, usually the most common cause is a heart attack, a myocardial infarction that has done damage to the heart muscle. Years ago, even when I started out as a nurse, we didn't have all these tools for heart attacks that we have now, like the stents and surgeries and the different medications. So a lot of times people who had fairly large heart attacks would not survive them. Now many do, but have some element of heart failure because of the pumping problems afterwards. So coronary disease, myocardial infarction, heart valve disease, if there's problems with the valves, if they are not together and blood leaks back down, that's called regurgitation. So we can have the valve regurgitating blood back down to the chambers. You also can have stenosis where the valve's real tight, so it doesn't open up very, very wide. So besides the blood flow is limited, the other thing is that that produces more pressure within the heart and causes problems in those chambers with that muscle stretching. Pulmonary lung disease, because again, the right ventricle pumps the blood into the lungs. So if there's a lot of emphysema or pulmonary fibrosis in the lungs, the lung pressures are higher. So the pressure, that back pressures into the heart is higher, causing more issues with the muscle, either thickening of the muscle or, and that's a lot what we see in with the lung diseases is more of a diastolic heart failure because of the pressure back from the lungs. Untreated sleep apnea for two reasons: the oxygen levels that affect the heart. And the other thing is that if you all held your breath for a second here, you would feel that pressure that builds up in your chest. So if you are stopping breathing multiple times during the night, your oxygen level goes down, the pressures within your chest cavity go up, and that, of course, it's that pressure problem again on those heart chambers. I think we talked about high blood pressure. If the heart has to pump against a blood pressure of 160, because that's the systolic pressure, let's say 160 over 90, it has to pump the, harder to get that blood out. So that's going to affect that ventricle. And then your resting pressure, it doesn't get to relax like it should if your bottom number or your diastolic number is high. Diabetes, which affects every organ in the body. Kidney disease. So if the kidneys can't get rid of the fluid and a lot of the enzymes and stuff it makes, but basically the fluid, that's going to back up into that's going to put more work on the heart because the heart's going to have to pump more fluid. Infections, particularly viral infections, and we call it viral cardiomyopathy. If you hear the term cardiomyopathy, it is kind of heart failure also. It's, cardio, which is the heart, myo, which is muscle, pathology, so cardiomyopathy. Particularly, again, viral infections like to cause cardiomyopathy. In this area, or certainly in central and upstate, Lyme disease and tick-borne viruses can cause cardiomyopathy. COVID is another big virus that can cause the cardiomyopathy. I don't know the exact process of that. It probably has to do with inflammation, which is a lot of the issues with the viruses and the organs. Many times with viral cardiomyopathy, it will reverse. It's one of the few that do, and not all the time, but it can be reversible. We'll have to wait and see what happens with the COVID cardiomyopathies, whether they are reversible or not. I haven't really heard that they are. The one thing I didn't put down here, because, we're all seniors talking, is that you also can get a cardiomyopathy from pregnancy. And that thankfully is reversible most of the time. Moving on, low oxygen levels, like we talked about, excessive alcohol use. So if you're drinking a lot, people who are alcoholics, those kind of toxins do affect the cardiac cells that are what drives the pumping of the heart. Recreational drugs, in particular cocaine, is very tough on the heart. First of all, it really increases the heart rate, and then it also causes all this, tightening of the blood vessels, so the heart has to work harder with less blood. Anemia, the same thing. The less circulating blood, the less hemoglobin you have. Hemoglobin transports the oxygen to the rest of the body. So it also transports oxygen to the heart. So if you are anemic, the heart is getting less oxygen because of the low hemoglobins. And that can even precipitate a heart attack. Autoimmune diseases. So diseases like rheumatoid arthritis, lupus, lupus in particular, those kind of diseases, because of the inflammation and that your own immune system is attacking your own cells, it can attack your heart cells just like it can attack, like in rheumatoid arthritis, attack your joint cells. So they have a little higher risk of heart failure also. But this side is probably your most common things. Of course, we're seeing a little bit higher of the viral cardiomyopathies because of COVID. Okay, so what are the symptoms? Well, shortness of breath is one of the big ones. It may be shortness of breath with exertion, climbing up a flight of stairs, or if, like, say, you're very active and you're going to the gym and now you can't do as much because you're short of breath. And we'll talk about, what levels of shortness of breath you need to be concerned about. Chest pain, you may have chest pain. Not everybody does. Edema or swelling, particularly in the legs and the abdomen. So, you feel kind of bloated, your pants don't fit as well, you may have fluid in the belly. What happens when you can't pump again, or you can't pump enough? The fluid and the blood back up south of the heart. So, and it's going to try to go any place that it can seep into. So the legs, the belly, sometimes if you're laying down, it'll be more in the back part. So any place that into the tissue, we call it third spacing. Increased weight. I probably repeat myself a little bit, but it's the really one of the standards that you have to watch when you're managing your heart failure. So, you're on the scale, you're increasing weight, you have edema, you're unable to lay down without breathing difficulty. Fancy name for that is orthopnea. So you go to lay down in bed and you're short of breath. You have to use some pillows, or you have to sleep in the recliner because you have trouble breathing laying down. Waking up at night, trouble breathing. And this kind of waking up at night is that you're asleep and then you wake up very suddenly and you can't catch your breath. Fatigue or feeling tired, not much, you're losing your stamina. You may have a dry cough, especially at night. Generally with heart failure, you don't cough phlegm up. So self-management. If you have congestive heart failure or cardiomyopathy, daily weights are really essential. And we have all this fancy technology and a gazillion different medications that are all appropriate and all have their place. But the low-tech thing like daily weights is really important to catch things early. The more fluid you put on or backs up, the more your heart has to work because it has now trying to move more fluid. And also your blood pressure goes up because you have more fluid in your blood vessels. So then you get into a vicious circle because then the heart has to work harder, so it's having trouble, so more fluid backs up, so the heart has to work harder, etc., etc., etc. And then you get into this downward spiral. So that's why you want to catch it early. If you're waiting for things to, to see swelling in your ankles or your legs, you could have 5 pounds or more of fluid by the time you see swelling in your legs. So, daily weights, same scale, same time of day. The general rule, and again, your healthcare provider, your doctor may have different numbers for you based on your heart failure, but the general rule about this if you gain 3 pounds in 24 hours, that's generally fluid, not fat, because your body can't really convert that Thanksgiving dinner into the fat that quickly. So 3 pounds in 24 hours or 5 pounds in 1 week. And that's where you want to notify whoever's managing your heart failure. Because then they can intervene, maybe give you a couple extra days of water medicine or something at that point. I would very frequently, either in the hospital or in our office, get people who were already 20, 25 pounds up on their fluid. And they had to go in the hospital then, because at that point we have to give intravenous medication to get that fluid off quickly. At this point, your doctor might watch it, see if you gain more weight. You can say, geez, I had, a lot of salt that day with that Thanksgiving dinner. Give it a day or two. Or he may say, take an extra water pill. I mean, there's much less aggressive things we can do at this point, catching it early. So daily weights, same scale. 3 pounds in 24 hours or 5 pounds in a week, unless your doctor has different numbers for you. Other things, weight control. Again, that will help bring the blood pressure down, and also has, less work on the heart. No smoking, and limit your alcohol intake. Generally we're, talking, a couple, 3 drinks a week, or less. Exercise, but as your healthcare provider recommends. So everybody would be different. We talked about the levels of heart failure. One size doesn't fit all. But again, the stronger you can make the rest of your muscles, your leg muscles, your diaphragm is a muscle, it helps that the heart doesn't have to work so hard when you exert yourself. Cardiac rehabilitation, if appropriate, is also a wonderful thing. It's supervised exercise. So you're on a heart monitor and they're monitoring your oxygen, so you can get that comfort of knowing how much exercise you can do. There's education. And the other thing I think is important is you're in a class, in a group with other people with your same problem. Most of the time, all the time really, the patients we've sent to either cardiac or pulmonary rehabilitation have gotten a lot out of it and have felt it was very helpful, the education, but also the support system they developed with other people that had the same problems. Diet recommendations. Generally, if you have heart failure, they're going to want to limit your salt. Salt pulls in fluid, so into the blood vessels. So the more salt you have, the more fluid shifts you're going to have, because of the extra salt needs the fluid. So generally, low sodium or low salt, 2 grams per day. So I'm sure you want to look at the food labels. Anything that's processed, deli meats, canned soups, frozen meals, they generally are very high in salt. So you want to take a look at those. But that's generally you're going to be on a low salt diet. Fluid restrictions. Not everybody with heart failure is going to be on a fluid restriction. That's going to be based on what your healthcare provider orders. Generally, the worse the heart failure, the worse the pump is. You may have to watch your fluid intake, because it doesn't make sense to give you a lot of water medicine to get rid of the water, the diuretics we call them, and then you just drink 2 liters of fluid in. So, but for a lot of people, it's still very good to drink water and keep things flushed out. So that's going to be on a case-to-case basis. Also, because so many of the people with heart failure also have like coronary disease, low fat, low cholesterol diets. I think we probably know about those. Medications. There are tons, gazillions of medications, and different reasons why your doctor may start one over the other. I'm going to give you some broad categories of the medications they use for heart failure. Again, depending on your type of heart failure, your severity of your heart failure, other conditions. Some of these drugs are better if you have kidney issues. Some are better if you have diabetic issues, different things. Your doctor will try different ones. The kind of the pillar of medication for heart failure are called ACE inhibitors. And that stands for angiotensin converting enzyme. That's made in the kidneys. And it's made in the kidneys, it's an enzyme, in response to the output of blood from the heart. So if the kidneys perceive that the blood pressure is going down or the heart pump is not pumping as much blood, it will release this enzyme. Now, the problem with that in heart failure is that what it does to get the blood pressure up or the heart to pump more is to tighten up the blood vessels, and that will bring your blood pressure up. Again, more work on the heart. If you can visualize our body systems, our survival systems for something like, let's say, shock, where the kidneys or the heart perceive that the blood flow is going down. Our bodies were designed to react to that as if it was blood loss. And I don't know if they lived at the same time, but like being bit by or attacked by a saber-toothed tiger. So everything the body does in that situation is to try to keep the blood in. So it tightens up the blood vessels. It makes more clotting factors. All of these things are not helpful when you have something like congestive heart failure, because you have now tightened blood vessels, more pressure to pump against, more clotting going on. The kidneys are making, the worse the heart failure, the kidneys are making more and more of this enzyme, this ACE. So these drugs inhibit the kidneys from making this enzyme. It's an ACE inhibitor. There's also, they're ARBs, and they're in the same family. Some of the ACE inhibitors cause cough, this dry, nagging, annoying cough. And we can switch them to an ARB, which is also an angiotensin inhibitor, and they don't get cough. So angiotensin inhibitors, they also are very helpful with the kidneys. So a lot of these will be, a lot of times, the first drugs that they start. I have a list here of like the common ones with the common names. Entresto's on the commercials all the time because it's the new one. The two big drop-down ones usually are lisinopril or losartan. Lisinopril is the ACE inhibitor. Losartan is an ARB. The other big category of drugs that they use for heart failure are beta blockers. Beta cells, we have alpha cells, beta cells, and they do different things, increase the heart rate. Again, if we're the beta cells, the beta release will increase the heart rate, increase the tightness of the blood vessels. Beta blockers will block that so that it will decrease the heart rate. It'll help. It also helps the heart beat stronger. The downside of beta blockers is a lot of people have a lot of fatigue when they first start them. It generally goes away, but the beginning is kind of tough. And the two drop-down ones are metoprolol and carvedilol, but there's many of them, but those are kind of the common ones. Some people with heart failure will be on nitroglycerin if they also have, say, coronary artery disease. So they'll have the pills they put under their tongue as needed if they have chest pain, or patches. And one thing nitroglycerin does, it does relax the blood vessels. So again, the heart doesn't have to work so hard. This fancy one, the and I'll probably mispronounce it, dapagliflozin, it's actually a diabetic drug that where they were using for people to control their diabetes. And then through studies, they found it really works very well with heart failure also, with or without diabetes. So that's kind of one of those drugs. It has been approved for treatment of congestive heart failure alone. If you're diabetic and you have heart failure, this may be a good drug. Your doctor may look at that. Diuretics, and those are kind of a lot of the mainstay. Those are the water medicines, get you to pee more. A lot of people hate them because they, you know, they got to go to the bathroom all the time. That's why I put that cartoon there. Next rest stop, 52 miles. And those are some of the basic water medicines, the Lasix, the furosemide, hydrochlorothiazide. Those are probably the two most common ones as an outpatients. But again, depending on sometimes other things that are going on, or your electrolytes, because some of them, like Lasix, will deplete your potassium. Other ones, like the spironolactone, will increase your potassium. So it will depend on that. Some people will be on anticoagulants. Not all. It's not a necessary thing with heart failure. It all depends what else is going on. And I saw a question about atrial fib and heart failure, and I'll add that in. But of course, if you're in atrial fibrillation or a funny heart rhythm, you may be on blood thinners. And you may be on cholesterol-lowering drugs. So they'll try to get, most cardiologists will try to get your cholesterols down pretty significantly. The LDL, or the bad cholesterol, down at least below 100. Cardiologists kind of like it below 70, so they may push it down even more. But that'll be up to, again, what the cause of the heart failure is, and what your lipid profile looks like. Let me just interject in here with a question about the atrial fib. Yes, there's a big connection about that. The atrial fib does also increase the work of the heart. And one of the things is, especially if it's maintained at a high heart rate. So when you have chronically high heart rates, it again strains the heart, where the pump, then eventually the muscle in the pump is affected. The other thing that goes on with that too is that atrial fib, outside of having valve disease within your heart, because that can cause atrial fibrillation. It's connected quite closely with sleep apnea. So that kind of combination, atrial fib, untreated sleep apnea, so you have the high heart rates, the low oxygens, really can precipitate heart failure. But the long-term increased heart rate is a lot of times the culprit in the atrial fib. So many times they can't get you out of atrial fib, but if they can have you rate controlled, they're a little bit happier. And I don't know, I showed atrial fibrillation happens in those two upper chambers of the heart, the atrium, and that's where the pacemaker of the heart is. That's where the electrical stimulation starts. That goes down and makes the heart pump, and the upper chambers. So in atrial fib, you don't have the one pacemaker sending that electrical system down. Each cardiac cell can also initiate an electrical impulse, and it's the ultimate redundant system, because we want the heart to beat. So if something happens to the electrical system, we want something else to take over. In atrial fibrillation, they all want to be the boss up there. So all these irritated cardiac cells all start sending electrical impulses. And so your irregular And the atrium is kind of like a jelly. It's not moving in with one leader. It does go down to the ventricles, and then the ventricles pump. So it puts a lot of stress on the heart. Just in many times when you're not on medication, your heart rates can easily be 120, 130, which is too much strain on the heart. So I hope that answered that question. If not, send up, because I love questions. So another important thing in your management: when to call your doctor, when to call your healthcare provider. So on the one side here, again, we talked about this, but I'm going to talk about it again because I would talk about it a lot and people would still come in 20 pounds heavier. So weight increase of 3 pounds in 24 hours or 5 pounds in a week, or whatever your doctor has given you. Sometimes they'll even say, listen, if you've had it for a long time and you're really good at managing yourself and you weigh yourself every day, they may give you instructions. You gain 5 pounds in this time, take an extra hydrochlorothiazide. So if you don't have specific instructions, or if you have instructions and you did the extra water medicine and you're still gaining weight, you need to call them. Increased shortness of breath. So you were doing okay, coming up the stairs, and now you're short of breath coming up the stairs. You would take, walk around the block. Now you're really short of breath taking a walk around the block. Any trouble breathing at night. So if you can't lay down to sleep, or you're waking up at night because you can't breathe, that is a call, next morning to the doctor. If you feel you're not urinating as much as you should, you're taking again, not everybody will be on diuretics or water medicine, but if you're taking water medicine and you're still not peeing, that would be a reason to call them. So then when should you go to the emergency room? Worsening shortness of breath. So, again, you've taken your medicine, what have you, you're still short of breath. Now, instead of being short of breath walking up the stairs, you're short of breath, walking 200 feet to the bathroom, getting out of bed. You have shortness of breath at rest. So you're sitting in the chair and you're still having trouble breathing. Chest pain. You find that you're really not going to the bathroom. You're not urinating. Those are really drop downs to get to the emergency room. So that's all I have to say. I'm to entertain. That's just an EKG, how the heart's pumping. The electrical activity. If anybody has questions, I would love to see if I could answer them.
Hello, I'm back to just a few comments here.
Okay.
So here we have urinate a few times during the day and wake up several times at night. What could be the cause?
Well, I'm going to stop sharing here so we can have a bigger screen. What could be the cause? Well, there could be several things. Something as easy as, what are you drinking during the day as opposed to maybe in the evening? I don't know if you're a man or a woman, prostate issues. Also, I'm sounding like a broken record. Sometimes getting up very frequently to go to the bathroom at night is another sign of sleep apnea. If you are on a diuretic, on water medicine, it may be the timing of when you're taking it. If you're taking it, in the afternoon, you may be getting up to, piddle during the night. So, that may be, so the easy things, take a look at your fluid intake, and if you have some medicine that makes you go to the, diuretics, what's the timing of that? You may want to take it in the morning so you're not peeing at night. Sometimes what happens too, with heart problems or kidney problems, you do mobilize or move more fluid when you're during the nighttime when you're laying down, and so you do urinate during the night. So there's a lot of things that could go on with that issue. It could be something really simple and, like the fluid intake or something you want to talk to your doctor about.
Okay, then we had another question above that. It says, for a healthy person exercising, can you get your heart rate too high?
Yes. I mean, I think there's a sweet spot from where you start, what your heart rate is where you start. I don't think generally the normal electrical system pacemaker of the heart in a normal rhythm will go up to 150, maybe 160. And after that, you're getting into sometimes different rhythms. So I guess my drop down would be about that. Yeah. I mean, I think that probably you're shooting for 120, 130. And again, it depends on your, absolutely healthy, or do you have some heart issues? What's the blood pressure at the time? But I would say 130 might be a sweet spot for a healthy person. I did see a question about, I think it was a healthy person with premature beats. Is that one there?
Yes.
Okay.
Mhm.
That's very, very common, especially in women, especially in women who are pre or just postmenopausal. As long as they're not bunched together or very frequent, they generally, the docs, your provider will do a workup, EKG, maybe an echo, just to make, some blood work, just to make sure there's not anything that needs to be fixed. Having your thyroid off can cause a lot of premature beats. Electrolyte disturbances can cause premature beats. But they'll check again the structure of the heart. Are the valves okay? Because that can cause a lot of irritation. And is the heart pumping okay? And if there's no what they call structural heart disease, and you're having some premature beats, and all your blood work's okay, they'll generally watch it. And sometimes you'll find things that make it worse or better. Caffeine will make it worse. Stress will make it worse. Sometimes, overexertion, things, you may find that. But if they're frequent, generally there should be a workup done. If the cardiologist, you don't have any heart disease per se, then generally they watch it. It doesn't cause heart failure if you have even if you have every third or so beat, a premature beat.
Okay, then there's a question about support groups for chronic heart failure.
Yes, I would probably direct you to the American Heart Association in this area. If you are like a cardiac rehab person, they have ongoing support groups even after you finish the cardiac rehab. So those are the two things that come to my mind off the top of my head.
Okay, and then the last question here, something about a disturbance in the eye. Color, circular light, edge of the circle is jagged. This happens randomly. My ophthalmologist wondered if it might have some sort of heart issue.
I'm sorry, I can't I can't answer that. I have no,
Okay.
I don't know. I mean, I'm sure that if you're having these eye issues, besides the ophthalmologist, I mean, I would, think about a neurological issue with the eye. Um,
Mm.
Not so much the heart, but I just don't know. Sorry.
Okay. All right. Well, I think it was a great presentation. Thank you for
Thank you.
taking the time to answer the questions. And thank you everyone for joining us today.
Yeah,
Enjoy
I'm
the rest
thrilled
of your
we had
day
so many people. Yeah.
and look forward to seeing you all as we end out this semester, and we'll be gearing up for the spring semester, as I mentioned earlier. So thanks again.
I think I'm doing lipids next week.
Yes, I
Yeah.
believe you're up again.
Yeah.
Is that virtual as well?
Yes.
You probably know better than I.
Okay,
right,
well,
great.
thank you all.
Have a great day.
Thank you.
Don't forget the survey at the end.